Welcome to this module on scaling up community-led and delivered HIV care to mitigate, adapt to, and recover from disruptions in HIV service access and utilization. The information contained in this module is designed for community-based workers, such as peer educators, paraprofessional client navigators, case workers, and outreach workers, and communities of people living with and affected by HIV. The learning objective of this module is to build the capacity of community-based workers on community-led and delivered interventions to mitigate, adapt to, and recover from disruptions to HIV services. After completing this training, you will be able to define and describe peer education and client navigation, describe how the COVID-19 pandemic impacted global HIV services, list the key components of PEPFAR's strategy to mitigate, respond to, and recover from interruptions to HIV services, and explain best practices and understand the path ahead. First, let's take a look at peer education and client navigation. Peer education is the sharing of knowledge by someone who is a part of the same social group, age group, gender, sexual orientation, race and ethnicity, occupation, socioeconomic status, and/or health status as the individual with whom the knowledge is being shared. The primary role of a peer educator is to help a person define their concerns and seek solutions through the mutual sharing of information and experiences. Peer education may include community outreach and education, referral for HIV testing, case finding, pre- and/or post-test counseling, referral to clinical, psychosocial, and other care and support services, adherence support, accompaniment to appointments, including support with transportation, routine appointment reminders, follow-up for missed appointments, tracking of those who have had interruptions in treatment, and advocacy for clients within multidisciplinary teams. The most important advantage of peer education programs is that they inspire trust. People trust those in a similar situation. People with HIV have the opportunity to discuss their personal circumstances with peer educators in a safe environment with someone who relates to their situation. Another important advantage is improved adherence. Peer educators can support adherence of people with HIV to care and treatment because they may have a deeper understanding of what the client is experiencing. Another advantage is community participation. Peer educators play a role in community mobilization, decreasing stigma and increasing support for people with HIV. Empowerment of individuals is an important advantage of peer education. Peer educators can increase people with HIV's confidence that they can make good decisions and take action. Peer education programs can help both peer educators and people with HIV make positive changes in their behavior in order to take care of their personal health and that of their families, which increases individual and community capacity in health literacy. Improved quality and cultural competence of healthcare service delivery is another advantage of peer education. Peer educators can help to improve the overall quality and effectiveness of healthcare programs by giving feedback to the clinic about the needs of people with HIV and the community. Task shifting and saved time are additional advantages. Peer educators can help free up the time of doctors, nurses, and social workers by providing basic education and counseling at the clinic. Another advantage is increased access to services and ability to minimize or remove obstacles. Peer educators can gain access to groups that are otherwise difficult to reach and encourage them to seek prevention care and treatment services. Similarly, peer educators can follow up with clients who have missed appointments since they are often from the same communities. Peer education can help reduce disparities in care. Because peer education can be a very effective way of reaching marginalized groups, peer educators play a significant role in reducing disparities in care. For example, peer education programs have been found to work well in prison settings where authority figures are often distrusted. Finally, peer education programs create a sustainable forum for seeking help and sharing information about support resources and positive coping strategies. A client navigator guides people with HIV through and around barriers in complex healthcare systems to help ensure timely diagnosis and treatment. The roles and responsibilities of peer educators are expanded when it comes to client navigation. Client navigation is similar to case management. A patient navigator is essentially a problem solver and a highly resourceful individual. A navigator can be a trained healthcare professional, such as a social worker or nurse, or a lay individual who can coordinate needed healthcare services. Client navigators are trained to anticipate and address and overcome barriers to care and guide patients through the healthcare system during a very difficult time. Client navigators can help improve the quality of care clients receive, and client navigation programs may help extend or even save people's lives. With the help of a client navigator, people with HIV are guided through the complexities of treatment, assisted in filling out paperwork or finding transportation to medical appointments, aided in identifying local resources, given ideas about communicating effectively with healthcare professionals, and encouraged and supported emotionally. The result is that people at risk for or with HIV have a greater chance of receiving a quick and timely diagnosis and any necessary treatments. In addition, services may be better coordinated and more consistent, resulting in improved outcomes. Client navigators help people with HIV identify and overcome barriers that interfere with achieving health-related personal goals and help ensure that clients effectively navigate and remain within the HIV services continuum. Barriers to quality care fall into a number of categories, such as financial, economic, language, cultural, communication, healthcare system complexities, transportation, bias based on culture, race, age, or other characteristics, fear, discrimination, and stigma, and lack of or difficulty understanding information. These barriers may cause clients to miss follow-up appointments or delay care until they are very sick. It is vital that clients receive continuous care from screening through diagnosis and treatment to ensure the best quality outcomes. People who often experience challenges when accessing healthcare, such as men who have sex with men, transgender individuals, sex workers, adolescents, and other disproportionately affected populations, can benefit greatly from this service. A client navigator's job is varied and complex, and the responsibilities often depend on the client, the healthcare system, and/or a variety of other factors, such as healthcare center policies. However, some universal responsibilities include coordinating appointments with providers to ensure timely delivery of diagnostic and treatment services, maintaining good communication and trust with clients, their families, and healthcare providers, monitoring client satisfaction with the care experience, and ensuring linkages to follow-up services. You may see or hear many different terms to describe peer education and navigation, such as peer navigator, peer educator, paraprofessional patient navigator, client navigator, peer support, peer-led program, outreach worker, caseworker, and many others. The community cadres that are the focus of this training include both paid and volunteer workers, who may be called peer educators, peer navigators, paraprofessional patient navigators, client navigators, caseworkers, or outreach workers. They all, however, describe a similar approach to health promotion, in which community members are supported to promote health-enhancing change among their peers. We discussed some of the differences between peer education and peer navigation in the previous few slides, but for the most part, these terms can be used interchangeably. Throughout the presentation, the term community-based worker, or CBW, is meant to encompass all those in the community setting who provide support to peers. Now let's turn to the effect of the COVID-19 pandemic on global HIV services. PEPFAR is the U.S. President's Emergency Program for AIDS Relief. PEPFAR is the largest source of funding for the HIV response globally. Since PEPFAR's inception in 2003, the U.S. government has invested more than $85 billion in the global HIV response, saving more than 20 million lives and preventing millions of HIV infections in more than 50 countries around the world. Every year, PEPFAR engages in a planning process to create a country operational plan, or COP, for each major country that receives funding. The COP is an annual plan that sets out PEPFAR's strategy for the following year. COP21 decides what happens during the budget year October 2021 to September 2022. COP21 sets out the goals and priorities for each country, strategies and interventions that will be used by implementing partners, where and who will be prioritized, the targets, and a detailed budget. The experience of PEPFAR since the onset of the COVID-19 pandemic has been mixed, but key top-line aims, including linking people with HIV with care and sustaining them on life-saving treatment, have been met, as overall program growth continued and continuity of treatment for people with HIV was largely successful. However, while PEPFAR and partner programs have shown remarkable resilience on treatment continuity in the context of COVID-19, the pandemic's impact on PEPFAR's and Global Fund's HIV, tuberculosis, and malaria prevention programs has been devastating. The pain has been particularly acute for women and children, as well as other vulnerable and marginalized populations, as these dual pandemics continue to reveal and exacerbate existing inequities in societies around the globe. COVID-19 has also shown the fragility of healthcare systems in some upper and middle income countries, which due to their relative wealth have lost their GAVI eligibility, and that could impact their ability to access COVID-19 vaccines once they are available. Setbacks to global and domestic HIV responses brought by the COVID-19 pandemic will be felt for years to come. Disruptions to HIV testing, prevention, and treatment services threaten momentum toward global treatment targets. Some impacts of COVID-19 on HIV services include restrictions on social gatherings and curfews severely impacting community-based activities, disruption to HTS, viral load backlogs, difficulty with accessing ART services for newly diagnosed patients as well as those already on treatment, anxiety among program staff, healthcare professionals, and community-based workers due to fear of infection, reported cases of violence, limited stock of basic supplies, such as hand sanitizer, soap, masks, etc., that are needed for prevention of infection. Clinical activities are generally ongoing, but physical distancing measures being put in place, particularly in relation to ART and PrEP. Top priorities during the COVID-19 pandemic include reducing the time spent in healthcare facilities while maintaining a client-centered HIV service delivery approach, implementing modified infection prevention and control measures to reduce the likelihood of COVID-19 transmission, continuing efforts to identify new cases of HIV while avoiding in-person gatherings, implementing virtual monitoring and evaluation strategies. The challenges of the COVID-19 outbreak highlighted several important lessons for HIV programs in the future. During an unprecedented public health emergency, HIV programs remained resilient through a combination of innovation and flexibility. Essential HIV services were maintained while keeping clients, healthcare workers, and communities safe. This was achieved through a combination of rapid scale-up of established interventions, as well as the use of novel strategies that had not been attempted previously. Next, we will take a look at PEPFAR's strategy to mitigate, respond to, and recover from interruptions to HIV services. Throughout the COVID-19 pandemic, PEPFAR has remained committed to continuing essential HIV prevention and treatment services while maintaining a safe healthcare environment for clients and staff. In order to meet the commitment to uninterrupted care and treatment for people with HIV and the prevention of deaths due to HIV-associated comorbidities, PEPFAR has been committed to adapting HIV services so that PEPFAR beneficiaries have the best possible outcomes within the context of stretched healthcare systems. Despite the disruptions caused by the COVID-19 pandemic, a number of countries have achieved epidemic control in COP20, and others will achieve epidemic control in COP21. With continued improvement, most PEPFAR countries are on a path to achieving program coverage goals. With that in mind, PEPFAR programs should highlight 4 key themes in planning and implementation for COP21. Number 1, client-centered services. Number 2, community engagement. Number 3, resilient and adaptive approaches. And number 4, support for sustainable capacity. COP21 guidance shifts language in a couple of areas. Old terminology has been replaced by new terminology. Retention is now called continuity of treatment, and loss to follow-up, or LTFU, is now called interruption in treatment. To help prepare programs for social distancing, community-based workers can collect contact information, such as telephone number, email address, and/or preferred social media, for all beneficiaries to help maintain virtual contact. Use a form that does not disclose key population or HIV status. Communicate with and reassure beneficiaries, especially those new to virtual outreach, how information shared using online and phone-based services will be kept confidential. And establish simple mechanisms to ensure that CBWs sustain social contact with one another under conditions of social distancing. They can use online chat groups, phone trees, or WhatsApp groups to discuss and share concerns and enhance group solidarity. PEPFAR's second priority after safeguarding the safety and security of staff and beneficiaries is to protect gains in the HIV response by ensuring a continuous supply of PrEP to reduce transmission and ART to maintain virologic suppression. The most critical intervention for all HIV programs is to accelerate and complete scale-up of 3 to 6 month dispensing of ART and 3-month dispensing of PrEP. This will minimize client contact with health facilities to both reduce COVID-19 infection and reduce burden on the facilities. One solution to reducing crowding at the health facility is the online reservation application, ORA, an appointment booking system that helps clinics manage client flow by forward triaging clients before they arrive at the clinic. CBWs should use virtual and online platforms such as the ORA, phone calls, SMS, WhatsApp, program websites, social media sites, and others as much as possible to make appointments for services that are safe and at low risk of COVID-19 exposure, provided that the beneficiary does not have COVID-19 signs or symptoms. Access medications, test kits, and other HIV commodities, and connect with other CBWs or a clinical provider. Supporting safe, sustained HIV service connections includes continuing HIV outreach services, maintaining HIV testing services, maintaining antiretroviral therapy and pre-exposure prophylaxis, ART and PrEP, tracking the impact of COVID-19 on HIV programs. Let's look at each of these activities in more detail. Best practices for key populations and the path ahead. With social network outreach, a person reaches others in their social network through online and mobile platforms. Social network outreach can be used to engage with populations at risk for HIV, including young people who are dating and who may have multiple sex partners or engage in transactional sex. Social network outreach includes both passive and active approaches and is implemented by online outreach workers who are trained staff. Outreach workers may engage untrained peers to make referrals to help extend reach. Technology can supplement these outreach approaches, including by linking clients to a website where they can take a self-guided risk assessment and book appointments for HIV services. HIV programs should use social network outreach in combination with other online outreach approaches, such as social influencer outreach and social profile outreach. Each has benefits and drawbacks. Social influencers tend to have broader reach but lower engagement than is possible through one-on-one online outreach, which is also called social network outreach. Compared to these other methods of outreach, social network outreach provides the most person-centered, in-depth client support, which generates a high conversion rate between contact and uptake of services. This makes social network outreach more suitable for people who need more assistance or would like to interact with a person, while social profile outreach, such as online ads, does not involve human interaction and may be better for people who prefer self-navigation and privacy. Implementers of social network outreach should mind the terms of use for online platforms, engage people with respect, and avoid being intrusive. The benefits of using online outreach include you can reach populations who are at risk for HIV and who have not been reached by previous HIV prevention and testing services and contribute to higher HIV case finding. You can reach existing beneficiaries already using online platforms in more convenient and cost-effective ways. And you can provide person-centered support and navigation to health services virtually, allowing beneficiaries to engage with the program with more anonymity, flexibility, and convenience. Digital recruitment of people living with HIV and clients prioritized for PrEP is best accomplished through social network outreach using social media platforms such as Instagram, Facebook, WhatsApp, YouTube, TikTok, Spotify, and others, and hookup apps such as Grindr and Tinder. These interactions aim to identify people searching for socialization, for sexual encounters, and those engaged in private sex parties. The monitoring of online social media platforms and hookup apps has shown that although there is a reduction, the number of people who use these platforms during quarantine to interact socially or look for sexual partners is significant. For those interested in services, telehealth appointments can be scheduled, and for those not interested in services during quarantine, CBWs can collect contact information to create a list of potential clients to be contacted after quarantine. CBWs can provide home delivery of prevention kits, which may include HIV self-testing supplies, condoms, lubricant, PrEP educational materials, anal douche, hand sanitizer, and others. PrEP is an essential component of PEPFAR HIV programming. COVID-19 presents an opportunity to move PrEP out of the biomedical sphere and into more creative, diverse delivery models that make it easier for people to access PrEP. Strong advocacy for PrEP service delivery should continue as part of comprehensive combination prevention, including counseling, condoms, and lubricants, or as outlined in country guidelines. PEPFAR recommends moving PrEP services away from and out of the clinics as much as possible, using virtual options for client initiations, refills, and check-ins, decentralizing dispensing of PrEP through community delivery, and moving to multi-month dispensing as much as possible. Decisions on whether multiple months of PrEP can be given on the first or initiation visit should be made based on an assessment by the client and provider together, according to the client's needs. If a client is committed to taking several months of PrEP from initiation, then it should be allowed. New enrollment versus continuing client. Factors to consider. Number 1, multi-month dispensing for new enrollment. Where possible, 3-month supply for daily or event-driven PrEP to minimize need for clinic visits. Number 2, counseling on side effects at new enrollment and providing options for clients to check in, such as by phone, WhatsApp, or video chat, with service providers if side effects are experienced during the first month or several months. Number 3, information on daily versus event-driven PrEP and pausing PrEP use. Offering support to clients to work through what options are best for them during COVID-19, either no change in PrEP use or taking a break. For men who have sex with men, switching between daily, event-driven, or no PrEP. Number 4, adherence support. Counseling for new and continuing users on setting daily reminders or prompts for PrEP using their phone or other tools, especially for those whose routines may have been disrupted by COVID-19. Number 5, addressing sexually transmitted infections or STIs. Where STI testing is available, enabling self-sampling or safe visits to designated health services. And number 6, other support that may be needed. Intimate partner violence, mental health, and drug use among PrEP users. COVID-19 has amplified stress and anxiety in many populations and increased vulnerabilities to violence and poor health outcomes. Hotlines, virtual or physically distanced peer support, and counseling services can offer critical wraparound support to PrEP users. COVID-19 safety considerations include the following. Number 1, how to communicate. Screen clients first for most acceptable communication method, either virtual or in person, and timing for follow-up. If virtual, what tool do they want to use, including phone, WhatsApp, video chat, etc., and ensure confidentiality and personal safety. Number 2, establishing flow for virtual client engagement. Frame to clients what will be covered for new PrEP enrollment or PrEP continuation. Number 3, home-based specimen collection. Provide the option of blood-based HIV self-testing kits and safe home specimen collection by mobile lab services or healthcare workers for HIV testing, creatinine, hepatitis B and C, and sexually transmitted infections or STIs. Number 4, home delivery of PrEP. What options are available and work best for a given client? For example, courier, postal service, or community-based organization pickup. Number 5, rapid revision of facility flow and systems. Pre-entry symptom screen, universal masking of both providers and clients, hand washing with soap or use of hand sanitizer, and visits by appointment only to limit drop-ins to thin out attendance and maintain physical distancing. Virtual case manager services focus on people living with HIV and clients prioritized for PrEP. Case management offers clients tailored, systematic, and quality follow-up. It is a data-oriented approach to ART and PrEP support that ensures transparency and accountability. Virtual case management provides several benefits. First, HIV programs can better connect with a growing user base of online and mobile platforms. Second, it allows case managers and community-based workers to meet client preferences for more private and convenient engagement. And third, it builds resilience in programs to maintain engagement during emergency situations such as the COVID-19 pandemic. There are 5 components of virtual case management. First, virtual means that part or all of the support services provided by case managers is non-face-to-face. This includes virtual channels, some of which are online, but all are mobile or phone or mobile device based. Number 2, tracked. Use of an electronic case management system to individually track clients, document their service uptake, and guide client support. 3, coordinated. There is a clear process for linking clients to case management services and managing handoff between case managers over time. 4, one-on-one. Case managers are assigned cases or clients and have a set goal to achieve with that client. And number 5, tailored. Level of support and service package provided to clients is differentiated based on treatment goals, client needs, and preferences. The COVID-19 global health emergency has dramatically underlined the importance of harnessing the full power of digital technologies to support public health programs and outreach. Lessons learned during the COVID-19 pandemic will continue to be implemented as best practices in client-centered care moving forward. Community-based ART, HIV self-testing, and use of social network approaches to identify key and vulnerable populations were integrated into standard program packages and should be continued and expanded. Interventions such as multi-month dispensing, decentralized drug distribution, and differentiated service delivery were accelerated to maintain continuous HIV treatment and should also be continued and expanded. Use of virtual platforms has proven invaluable and will increasingly be a key component of program planning, not only because of the benefits for health and safety, but also the potential for advances in efficiency and cost savings. Continued expansion of online, virtual, digital, mobile services will include home-based HIV testing. The main purpose of home-based HIV testing is to bring HTC services to households, overcoming some of the barriers of access to testing services and providing testing to individuals who might not otherwise seek services. HIV post-test counseling and service linkage. The goal is for clients to understand their HIV status, understand their service options, including virtual services, and get linked to appropriate services. Virtual components include scripts for conducting phone-based post-test counseling and service directories for real-time referrals. Index testing for people with HIV. The goal is for people with HIV to help their infected partners to know their HIV status. Clients need to know why index testing is important and how index testing can be carried out virtually and safely. Virtual components include call scripts to follow up with clients for index testing, using anonymous SMS options to reach contacts, and electronic referral tracking tools. ART initiation and support. The goal is to achieve viral suppression. Clients need to understand the importance of adherence. Case managers and community-based workers can help generate demand for virtual case management. Virtual components include routine phone and SMS reminders, follow-up telephone and video calls, and electronic case management systems to record and track service uptake. PrEP initiation and management. The goal is for HIV-negative clients who start PrEP to remain HIV-negative. The client needs to understand the importance of adherence. Case managers and community-based workers can help generate demand for virtual case management. Virtual components include phone-based adherence reminders and phone SMS-based screening reminders. Digital health platforms provide a vital central hub, linking together disparate and unconnected systems and applications, enabling faster, more efficient, and more reliable information exchange, and promoting increased access to health data across a range of devices. They provide a unified platform to provide, coordinate, and track services, such as demand creation, service booking, through platforms such as the ORA app and QuickRes, client records, reminders and adherence support, telehealth appointments, and educational messages, tools, and gaming. Infection prevention and control measures, or IPC, at healthcare facilities will also be critical, not only for COVID-19 control, but also for preventing the spread of tuberculosis and other infectious diseases that can be transmitted in a healthcare facility setting. Here are a few questions we can discuss as a group. What do you think about the concept of community-led and delivered interventions to mitigate, adapt to, and recover from disruptions to HIV services? Do you think it's helpful for your work? Do you think it will improve the care that you provide to your clients? What do you think about the concept of community resiliency in healthcare? Do you think the concepts in this training module will change the way that you relate to your clients? Thank you for your attention and participation. This is the end of this training module.